And just bear with me for a minute. So her recent award was the best CEO. You got the award for
the CEO award.
Yes, the CEO award. And
that's fine. That's fine.
Yes. So now we start with how to see. I'll just give you a brief thing. For me, as a gynecologist, I come across so many young girls with small lumps, small nodules, and you know it in your heart that it is not that small to be ignored, and it has to be removed. The minute we say that iski surgery karani hogi, nahi ma'am wo scar nazar aayega, you know, how she's not married, and is that the only answer? And then they just will go away. They will go on for alternative medicine treatment and come back with the same position. So here we have today Dr. Geeta telling us how these benign lumps in the breast can be managed without seeing the scar. Over to you, Dr. Geeta.
Thank you very much for your kind introduction and a very warm welcome to all my friends here. It's always good to be back with friends, even if it is virtually. Like you said, you know, a lot of young women always worry about scars. More than them, the mothers are very worried about scars in the breast if they have a lump, or sometimes even multiple lumps, which is something that we all deal with all the time. So today I'm going to talk about a technique by which you can actually go scarless and you can barely see that, you know, something has been done on the breast. It's that good. So if you look at a lump in the breast, we always talk about triple assessment whenever there is a lump in the breast. And one of the arms of the triple assessment after clinical diagnosis and imaging is how to arrive at a cytological or a histological diagnosis. So there are various methods by which you can do it. And if you look at FNAC, the sensitivity is about 82 to 98%, and the specificity is 77 to 100%, but a lot of it depends on, you know, who is doing it. So core biopsy, if you do a blind core biopsy, essentially meaning that you feel the lump and you do it, then the sensitivity is about 90 to 95% and a specificity of 100%. But if you do a ultrasound guided core biopsy, it is even more accurate, especially in smaller lesions. The accuracy and the sensitivity of an ultrasound guided core biopsy is very high. The specificity is same as for a core biopsy. You'd rarely ever find a false positive with it. So then the fourth kid on the block is the vacuum assisted biopsy, which is going to be the topic of discussion today. And you realize that the sensitivity of the vacuum assisted biopsy is very high, same as for an ultrasound guided core biopsy for large lesions. But if you look at smaller lesions, it does better than even an ultrasound guided core biopsy. And also for areas where there are microcalcifications in the breast, there a vacuum assisted biopsy is of huge importance. And the specificity, of course, of a vacuum assisted biopsy is also close to 100%. So I'll just briefly talk to you about core needle biopsy, because if you realize in our practice, even today, a lot of us still continue to do an FNAC, which is not a bad technique. But if you want a more accurate diagnosis, if you want to reassure your patient at the end of that result, I think a core needle biopsy is the way to go. And if you look at what the guidelines are today, the guideline today is that even if you have a large lump, don't rely on a blind core needle biopsy. An ultrasound guided core needle biopsy is what one should be doing. So if you look at an ultrasound guided core biopsy, a lot of times there is this confusion, you know, what all things I'll need to do. Do I need to do a PT-INR? I can assure you it took me 4 years to convince my radiologist that you don't need a PT-INR for a breast biopsy, because a breast is a superficial organ. It is amenable to compression, and you can actually deal with most of the bleeding with just pressure, even in those who may be on blood thinners also. So the requisites to do is, like I told you, don't do a blind biopsy. It is always good to do it under ultrasound guidance. And we don't do any FNAC anymore for breast lumps. We only reserve it for axillary lymph node, because that information is also important. Because if that lymph node is positive on FNAC, then I know that I don't have to do a sentinel lymph node biopsy in that patient. So what do you do for a core biopsy needle? It's a very nice automated core biopsy needle that we use. And the gauge that is recommended is a 14 gauge core biopsy needle. To get that sensitivity of 97 to 99%, you must use a 14 gauge core biopsy needle, but you will see a lot of variation in this. A lot of people use an 18 gauge, even a 20 gauge, but there the tissue, size of the tissue can be kind of a little less as compared to a 14 gauge core biopsy needle. And you must take at least 4 to 5 cores, nothing less than that. Because 1 core or 2 cores, you may actually miss target and you may not get the right answer that you're looking at. And once you've done a biopsy, you can leave a marker if required. This is especially for those patients who are undergoing chemotherapy. And if suppose the lump were to shrink to a size that it is not visible, then that clip will be visible and the clip will guide you to the surgery. And one must always mention the exact location of the sample lesion. In fact, I would do a tattoo of the original lump so that I have a footprint of the original lump, because after chemotherapy, if that lump were to disappear, I would know exactly where to go. So this is how the core biopsy is done, that you go along the ducts, you place the transducer. This is the transducer that we're talking about, the ultrasound guided transducer. Okay. And then you place it on this on the skin, and you need to make a little pinpoint, not a pinpoint exactly, just the tip of the knife should be placed on the skin, so that you can put in your needle through that, the core biopsy needle. Because for a 14 gauge needle, you definitely need a little nick on the skin to be able to enter. So if that is the lesion, you can see that is the needle which is coming in line. So that is the needle there. You can see the core, the biopsy needle sitting right in the center of the lesion. And once you fire it, it takes the core and you can withdraw the needle and then put the core in a formalin-filled bottle for biopsy, for histopathology. So what you're doing with the needle is you're actually entering through one hole, but you can direct the needle in different directions. So you're sampling suppose if that's the lump, you're sampling it in different directions. So even if it is the heterogeneity of the tumor is addressed by putting it in different directions. So that brings me to the conventional method of treating a breast lump. If there is a breast lump here, so what I would do, which I think still serves you well, especially in women who are older, if you want to do a fibroadenoma excision, you can put in a cut there and remove these lumps from the same incision and close it. And the scar is beautiful. You don't even make out after 6 months or so, you can't see it. So now we're coming to this new kid on the block, which I said is the vacuum-assisted breast biopsy and Scarless lump excision, because you can do a biopsy with this technique and you can do a Scarless lump excision, but then there are certain caveats to it, which I will discuss. So the vacuum-assisted biopsy, breast biopsy, was developed in 1995 by Fred Burbank. He was a radiologist, and Mark Richard, a medical device engineer. So you see what a great collaboration between an engineer and a doctor. So this brought about this technological advance in an effort to overcome the shortcomings of a core biopsy by using an automatic biopsy gun. So what they did was they started off with stereotactic. When I say stereotactic, I mean it's when you do it on the mammogram machine, you would say it's a stereotactic method of doing it. So when you say a VAG, vacuum-assisted biopsy, it can be done under ultrasound guidance, it can be done under your MRI guidance, or it can be done stereotactically also. So stereotactic VAB was introduced by Burbank and Parker in 1996 as a diagnostic tool to evaluate suspicious lesions. When you say suspicious lesions, these are basically screen-detected lesions, which could be in the form of microcalcification. And if there is a small area of microcalcification, sometimes trying to do a core biopsy, a stereotactic core biopsy can be quite difficult. That is where stereotactic vacuum-assisted biopsy can be very, very useful. And for the first time, it was performed by Zanis in 1998. And the uptake was so huge that in 2000, actually in Korea, a lot of radiology centers, almost 50% of them had the vacuum-assisted biopsy device. So this is how it works. If it is stereotactic, that's the mammogram machine, and the breast is placed there, and then you work out the coordinates on the stereotactic machine, and then you are able to target that lesion with the help of stereotax. So you can use the ultrasound, or you can use MRI, although MR-guided biopsy is a very expensive proposition. And in our country, there are only 1 or 2 centers which do the MR-guided biopsies. So what is the good thing about vacuum-assisted biopsy? One, it is very fast. In experienced hands, you can do it as quickly as you can do a core biopsy. The sample size is bigger, definitely bigger, because I'll show you what kind of biopsies you get with a vacuum-assisted biopsy system. And it has a very high positive predictive value and a negative predictive value. And here, there is only a single needle insertion. You can see the sharp tip of this, the vacuum-assisted biopsy gun, which is inserted only once. You don't even need a knife, because this by itself can act as a knife. And then you can use it for a Scarless lump excision, which I will come to. And you can do it on an outpatient basis. Patient can go in, get the biopsy done, and go home. Even a lump excision can be done as an outpatient procedure or a daycare procedure, and can leave the same day. And it is done in the ultrasound. It can be done in the ultrasound suite. But if a patient is very anxious, then you can take her to the theater and do it there as well. So like I told you, see, this is the size of the sample you're getting, such big cores. So this is almost 3 centimeters in length, and the thickness can be anywhere between 4 to 5 millimeters. So the indications of a vacuum-assisted biopsy system is, like as I said, it's diagnostic or it can be therapeutic. So when we say diagnostic, it is for biopsy purpose. And when I say it is therapeutic, it is, of course, to remove a lump. So when, there are a lot of times that you would find a mammogram report, which there may be a palpable lump, there may be a non-palpable lump, and the classification on BI-RADS is a category 3. So category 3 could mean that you should keep the patient on close follow-up you should be repeating an imaging after 6 months, and small 4A nodular lesions. When you say 4A nodular lesions, it means that this patient has a 3 to 15% risk of malignancy. It is not very high in 4A lesions. In small 4A lesions, it's probably closer to a 3 to 5% risk of malignancy. So lesions smaller than 5 millimeters, which could be small stellate lesions, can sometimes be very difficult to remove with a standard core biopsy. It is sometimes very difficult to reach it. Sometimes you have these invasive lobular carcinomas, which can extend over a large area. And lobular carcinomas are the ones which you actually may not see on mammogram. You can miss it on ultrasound, but there is something that you're feeling and you may still not find anything. And it could be seen on an MRI. So here, when you have this area, there is a heterogeneous hypoechoic area on ultrasound, but you're not seeing a definite lump. You require a broad sampling. So that is where VAP comes in very handy. And sometimes you have a solitary complex cystic area. When you say complex cystic area, it essentially means that either there is a cyst which has got a lot of septi, or it is a cyst with a thick wall, or it is a cyst which has got a small solid area in an otherwise completely normal breast parenchyma. So how do you sample this? So this is a good case for a vacuum-assisted biopsy. Then solitary papillomas. Solitary papillomas can be very tricky. Solitary papillomas cannot definitely be classified as benign or malignant just on the basis of imaging. They're very tiny things within the duct. So how do you address that? Here, a vacuum-assisted biopsy can be both diagnostic as well as therapeutic, because if it is a small little papilloma only without any atypia, then the treatment is done and over with just the vacuum-assisted biopsy. Microcalcifications. Nowadays, the ultrasound resolution is so fantastic that even microcalcifications can be picked up. Earlier, the dictum was that mammogram is the best investigation for microcalcifications. It still continues to be, But because of high resolution ultrasound, you can actually pick them up on ultrasound. So these can also be, be extracted by the vacuum-assisted device. For lesions close to the nipple, the thoracic wall, or the skin, or the axillary region, again, a vacuum-assisted biopsy device does wonders. If it is close to the skin, one must be careful because, like I said, this is a vacuum-assisted system which pulls whatever it lies under. So you have to create a space between the skin and the lesion with that can be easily done with local anesthetic. You can inject local anesthetic between the lesion and the skin and then comfortably do the vacuum-assisted biopsy. And of course, vacuum-assisted biopsy can always come in if there is an inadequate FNAC or a core needle biopsy report. So if there is a benign lesion, so this is when I say this is the therapeutic bit of the vacuum-assisted biopsy, and you should be doing it only and only in a benign lesion. You should try and not do it on a malignant lesion, because a malignant lesion, if you were to do excision, then you're left with nothing, and you must ensure that you put in a clip there so that if you have to go back and excise more for margins, then you have to be able to do that. Because if you excise a malignant lesion on vacuum, with a vacuum-assisted biopsy system, you have not taken margins, which is not desirable in a malignant lesion. But for a benign lesion, it is a proven fibroadenoma. The size is not larger than 2.5 to 3 centimeters. You can go ahead and excise it with a vacuum-assisted biopsy device. But if there is a slightest suspicion that this may turn out to be a papilloma with atypia, or it can be precancerous, meaning a ductal carcinoma in situ, or a malignant lesion, one should ensure that a clip is placed there, because that is the only guide to further surgery. So in a multi-center non-randomized study of 124 women with low-risk palpable lesions, essentially meaning most likely fibroadenomas, the complete removal was possible on VAB in about 98% of patients with an 8 gauge. The thicker the gauge, the higher the likelihood of having a complete excision, and 96% in those who use 11 gauge. Complications were minimal, and the patient was satisfied in about 97%. And what was even more remarkable was 98% of the patients said that they would recommend the procedure to others. So then comes this problem of histological underestimation of disease. This is something that is that's something that we don't want to see. But if you look at a 14 gauge core needle biopsy, you could underestimate ADH meaning atypical ductal hyperplasia, in 44% of patients. And in a 14 gauge VAB, it comes down to 39, but in even a larger gauge, it can come down to 19%. So one must be guarded against this underestimation of disease, because a lot of times you will find that this histological underestimation, which happens in benign papillary lesions, would necessitate surgical excision in about 10 to 20% of patients. With VAB, however, if they are benign, then you can just follow these patients up. They have talked about phylloids also, where they say after VAB excision, the local recurrence rate is only 3.3%. But this must be taken with a pinch of salt, because the incidence of phylloids tumor is low. So when you have a disease which has a low incidence, then you cannot make a recommendation based on a vacuum-assisted biopsy, the vacuum-assisted excision, because phylloids is known to recur. And if you don't take margins for phylloids, then you could land up with a big disaster, because benign phylloids, when it recurs, could be a borderline or a malignant phylloids. The other interesting thing that one should look at is epithelial displacement. So this is something that everyone worries about when you do a biopsy. So they found that in 352 surgical specimens of women with prior diagnosis of cancer with a core needle biopsy, they found displacement of malignant epithelium in 32%. And this displacement was about 37% after an automated gun biopsy and 38% after a palpation-guided biopsy. But this was 23% after VAB. So this may be less frequent after VAB, because in VAB, what you do is, once you place the VAB needle under the lesion, you're not moving the needle. you are the location remains the same. Of course, the space where the vacuum is applied, of course, can rotate, but it does not move within the breast. So there are two ways one can do a lumpectomy with the vacuum-assisted biopsy system. So this is the space within the needle where where the vacuum is created, and this is the blade which will progress ahead like that and cut the tumor. So this pushes forward, cuts, this sucks, and this, once it is sucked, then it goes into a chamber where the tissue is collected. So cut, suck, and it is collected, and that is how, I'll show you a video on how this happens. It is very, very fascinating, and you'll see how the lump disappears completely. So this is what I meant. That is how it cuts and it rotates. It can rotate at 360 degrees. So you can rotate the needle. You don't have to rotate that. These are settings on the ultrasound machine. There is a machine where the VAB has to be controlled by just your hand. You can just decide what kind of arcs you want to remove. So you would, if you say this is the 12 o'clock, the first cut can, first rotation can be 12 to 3, then it can go from 3 to 6, 6 to 9, and 9 to 12, and the whole lesion can disappear. So best position, this is the 12 o'clock position, and you'll see that it takes out the entire lump from the top bit, and then you can rotate it at 360 degree, and the rest of it can be taken up from the back. But here, this is the best placement where you place it at 12 o'clock, and the entire lump will fall into this chamber with vacuum and cut. So I'll just show you an animation first, and then I'll show you a real case, just for a good idea as to how this happens.
La biopsia se hace en posición tumbada.
So that is the transducer, and that's the lump. So placing the transducer in the right hand or the left hand, whichever you're comfortable with, you will put in the needle, insert the needle under guidance. So this needle is a disposable needle. So you have placed it right under the lump. That's the area, that's the chamber into which it is going to be sucked. The needle moves forward, cuts, and the tissue is removed, and it is sucked into the chamber, collecting chamber. So that is how small the needle entry is. You just need to tape it. So some amount of pressure is required because to prevent bleeding and hematoma formation. So that is how it looks. So this is a real, this is one of our cases that we did. This is the lump, and we placed the vacuum-assisted biopsy needle into that lesion. Oh, it's not working. Just a second, let me see. Okay. I'm sorry, this video is not working, but anyway, you've got an idea as to what happens. So this is where the needle is. It's actually very nice when you look at it. So that's the fibroadenoma if you look at it, and these are the core. This is how the fibroadenoma is removed in so many pieces, and these are all sent to the pathologist who will look at each of them to just be very sure that it's a fibroadenoma only. And that is the kind of scar you have at the end of the procedure. So like I said, for papillary lesions, it's a very important thing. You would have seen patients who come with nipple discharge. If it is nipple discharge, you have to address it surgically. But if there is no nipple discharge and there is only a papillary lesion with no atypia, they have a low potential of malignancy, but they are still considered as B3 lesions. B3 lesions meaning to be kept under follow-up. They can be easily excised with an ultrasound guided vacuum-assisted excision. And it is an easy procedure, well tolerated. But if there is an atypia, then you should try and leave a clip there. That is very, very important, because if it does come back as DCIS, you have to take that patient up for surgery. So this is what they have recommended. This is the management of papillary lesions as recommended by the breast screening program of the UK. And if there is a B3 lesions with no atypia, then you should do a vacuum-assisted excision. This is a great alternative to surgery. But if there is atypia or there is DCIS or any papillary carcinoma, all those need to be treated surgically. But you do realize in a B5, obviously, B5 essentially means chances of malignancy are very, very high. It is basically confirmatory for malignancy. They should undergo surgical treatment. So like I said, this is the NHS breast screening program guidelines. Use a 7-gauge papillary lesion with no atypia. You can do biopsy with a 14-gauge and do a vacuum-assisted excision if there is no atypia with a 7-gauge, and then look at it. If there is no atypia, you send her back to screening. If there is atypia, you have to do surgical excision. If there is cancer or DCIS, then therapeutic surgery has to be performed as you would do in any case of cancer. So this is how the papilloma looks. Very difficult. This is one of those things which can be picked up only on ultrasound, not seen on mammogram. So this is a patient who had papillary lesion with no atypia and a 14-gauge on 14-gauge core biopsy. And this was excised with a vacuum-assisted system. So if you look, you definitely would want to know what are the risks of the procedure. So bruising is very, very common. So once you're done with the procedure, you must give a lot of, do a compression for at least 5 to 10 minutes. And sometimes ice packs also help, something that I have used in my patients where, you just use ice packs and do a compression for 5 minutes and then another 5 minutes of compression and then do a pressure dressing and then let her be. Pain does happen because, sometimes there is a hematoma would form in the space from where the fibroadenoma was removed. So that is okay. Bleeding can happen. We've had a situation where there was an arterial spurt, in which situation we had to increase the incision and catch hold of the bleeder. So you'll have a small scar at the site. You can barely make it out. So that is not an issue at all. Less common risks of the procedure, fainting. You could have a vasovagal because of the kind of thing that is being done in the ultrasound suite. Sometimes parts of the lump may be missed, especially if you were to do it in a slightly larger lump. Then you may not be able to do a complete excision, in which case you may have to bring her back for a second sitting. Wound infection, again, a very, very rare thing. It's only a little tiny little hole. So I haven't seen any wound infection in the patients that I have done this. Thank you very much. So that was about, I really wish I could have shown you that video. Let me see if I can do that. I will stop share. So while you're asking me questions, just a second, let me.
So this was a wonderful presentation. And yes, I can almost see how comfortable it will be for the patients. No need for admission, no need for any pre-investigations. Like you said, PTNR karao, ye karao.
Okay, yeah. So that was about the presentation.
You'll be able to show us the video?
So let me see if I can get hold of that video.
Yeah. So the first thing was, there is, she just...
Are there any questions that you want to ask? I'm happy to answer.
Dr. Geeta, I think, we were delighted to see things are not available. How a person's things should not be missed out. So the question is, I think, to my mind also, I'm a modern medicine person, but I feel even a small scar doesn't matter. But till the time now, this is #1 problem, and I feel very surprised that even a doctor community, you find advanced cancers are missed out and they report to you very late. तो कुछ ऐसा सिस्टम बनाएं जिससे कि कहीं पर भी पेरिफेरी में बैठा हुआ आदमी कहीं पर भी सर्जन से अपनी छोटी बायोप्सीज करा ले और उसमें कोई चीज मिस ना हो जाए, उसके लिए कुछ बात करें यहाँ. क्योंकि I find, for a small biopsy to get onto MRI kind of biopsies and things like that, which makes things very expensive. That's the reason I find, why the breast carcinoma is increasing in this particular country. And I think, you should got to give us the solution. I feel very sad. There are 4 people every month the doctors are diagnosed with breast cancer late.
So, ma'am, there are various reasons to it. So it is, unfortunately, you will see that there is nothing to do with the level of education.
Yes.
The more educated you are, the sense of denial is so much stronger. I have seen an IAS officer with maggots in a breast carcinoma. And she was, she came down from another state, but she had maggots in her breast. I mean, it is kind of unimaginable that somebody of that caliber should be coming to you with maggots in a carcinoma breast situation. So to our other question as to what should people do when, core biopsy is not available. So we have to look at solutions to our problem. I'm very glad when patients come to me with an excision biopsy and say, look, I have been diagnosed with cancer. The doctor there in my place, excised this lump. I'm very glad when that happens. I'm very worried about those people who would do an FNAC. Your index of suspicion is high, but when the FNAC comes back as negative, you say it's negative and you let them be.
That's wrong.
That's wrong.
Is wrong.
That's wrong. So if you were to do an excision biopsy and arrive at a diagnosis, she still has a great chance because now she has a diagnosis. So I'm very happy to treat those patients who come with an excision biopsy and say, कि डॉक्टर साहब उन्होंने गलत कर दिया. I said, बिल्कुल गलत नहीं किया, बहुत अच्छा किया. नहीं तो यही चीज आपकी बढ़ जाती है और आपको पता ही नहीं चलता. कहता हम पहले ही आ जाते हैं आपके पास. मैंने बोला वो तो कोई बात नहीं, हमारे लिए ये स्टार्ट पॉइंट है, पर उन्होंने जो किया उसके आधार पे ही हम आगे सोचेंगे. अगर वो ये चीज नहीं करते तो आप घर बैठ जाते आराम से and you would have thought that there is nothing. But in reality, this is the situation. So I'm happy for most women over the age of 40, especially 40. We take that as a cutoff, but if there is a high index of suspicion, please go ahead and excise. There is nothing wrong with excision. But in a city like Delhi, of course, you have got all the options. I'm not saying that's the best option, but it is still a better option than leaving the person alone. Because if you can do a core biopsy, you can plan better, you can do a conservative surgery. Because a lot of times these ladies who have a excisional biopsy land up with mastectomies. We should never think in our mind that she comes from a, poor background, she comes from a rural background, but a woman is a woman. And, that choice is hers. She wants to keep her breast. We might as well discuss that with her because I have been surprised a number of times. This has been my learning from my patients who said, why are you not giving me that option? I may be from the back of beyond, but I want to keep my breast. So I think the options should remain the same for all, irrespective of where they come from. So to improve that option, I think, if you were to do a core biopsy, obviously these options can be given upfront. If she were to come from outside with a lump excision, I'm still happy to offer a conservation after I have done my bits to understand if there is nothing else anywhere in the breast.
What is the cost like?
Dr. Geeta.
Yes.
The people and general people have in mind that in any lump, if his biopsy is taken and if it happens to be malignancy, it triggers off. What is your take on it?
Ma'am, that's not true, but there have been a lot of studies done. So there are some cancers in which we still don't do a biopsy because we know there is a possibility of spillage, but that's not true for breast cancers. You're absolutely right. This is a very, very solid myth, which even today, some patients come and say, look, I don't want a biopsy, you can do a frozen section. But our planning suffers because of that. If you're doing a frozen section and you are reasonably certain that it is malignancy, but then you do a wide excision, you do all those bits. But a diagnosis will help me do a staging properly. But if you don't have a diagnosis, you can't stage that patient properly. So all those things are there. So biopsy in breast does not cause breast cancer to spread. The reason I think I know the reason for this. The reason is that biopsies earlier used to be done in advanced cases. Usse pehle we used to do FNACs for small lumps, but then now it is biopsy for all lumps. Earlier, biopsies used to be done for advanced disease. So you would get a diagnosis and then the patient would go for a CT chest abdomen and find that there is disease in the lung, in the liver, and they would attribute it to the biopsy, which is not true. She always had advanced disease.
Yeah, it was already there.
Already there, yeah. So that is a misconception. So for breast, biopsy remains the gold standard. The point of, that's a start point. Irrespective of whatever imaging you may do, biopsy is mandatory.
And you're asking about the cost?
Cost of the VAB? So if you were to do a lumpectomy, it would cost you about 60,000. But VAB, every time that contraption that we use, that needle with the chamber, with the, all that stuff is a disposable thing. So the disposables cost about 20,000. So it would come to, if you were to do it in theater, it come to about 80,000. But if you were to do it in an ultrasound suite, it'll come to about 45,000.
40,000 is cost, बताओ. उससे अच्छा around जरा सा निक दे के निकाल के क्यों मत.
So I completely agree. A lot of times, patients do opt for lumpectomies, and we can do lumpectomies without scars, I can assure you.
Yes, especially in a young girl, and especially when she's unmarried. So
Yes.
somehow the parents are at ease that there is no scar. So it really helps a lot.
Very
And
true.
then when there are multiple lumps, then too.
So multiple lumps, you can do multiple sittings with VAB.
Okay.
You should not be doing too many in the same go, not more than 2 lumps in one sitting.
Okay.
But then, with the periareolar incision, I have removed 16 lumps in one breast because this girl was about to get married. And I said, we can just leave it alone because these are, father was very insistent that we should. We went ahead and did that. So it is possible to remove. If you've got a good size areola, you can remove as many.
And the cutoff size is 2.5 centimeters?
2.5 to 3 centimeters, not more.
3 centimeters.
Although there have been people who have done 5 centimeters also, but that's not a great idea. You need multiple sittings then.
Okay. So multiple sittings means she comes like today and then tomorrow and then onwards?
No. She comes back after 3 months, 4 months. Yeah.
Okay. So that is very tedious.
That is tedious, and you should not. Why? And the chances of hematoma, bleeding, all that goes up as the size.
Every time we do it. Yes.
Back to again the national perspective, for a biopsy or for taking a small lamp or 60 or 80,000 rupees is unthinkable for majority of the people. What will be your last message as far as the core biopsy is concerned for a diagnosis of whether it's benign or malignant? What is your say on it?
So core biopsy will slowly become mandatory, but I will still not run down the FNAC. It is better to put in an FNAC, fine needle aspiration cytology is better than nothing. So just because you don't have...
If it is positive, it is great. If it's negative, you need to have excision biopsy.
Means nothing, yes. And a negative FNAC means nothing. In a lump, it means nothing.
The problem remains as it.
Yes, as it is, absolutely. So core needle biopsy, I think, everybody needs to be trained in core needle biopsy. So if you look at most of the places, even medical colleges, you'll find that core biopsy doesn't exist. So that is something that you should learn how to do a blind biopsy. It's okay, you need to know. So even till about 5 years ago, I used to do blind biopsies, but I realized that, blind biopsies have their own disadvantages. You can have a large lump, a lot of necrosis in the center, and your needle could be just hitting the necrosis and come back as necrosis and you're nowhere. So an ultrasound guided biopsy obviously...
Geeta, people like you, when people are training laparoscopy in a surgical specialty and things like that, why you should have a national program just to teach the surgeons, how to take the biopsy properly. This should be your mission.
So great idea, ma'am. And now because we have these webinars and things, it's very easy to... I have got videos of blind biopsies, core needle biopsies. In fact, even things like, when should the sample go into the formalin? Because all that is important, because if your sample does not go into the formalin within the requisite half an hour to maximum that 1 hour, you can lose information on the tumor. So all these are very small things that people don't talk about, but I think it is very, very important. I did a workshop on these little things, how does the specimen from the OT table to reaches the pathologist? Because we have to make life easy for the next person. If you're not mindful of it, then you would actually land up losing a lot of crucial information for the patient. I think it's a great idea. So now I have another thing to work on. So I'll bring out all those videos and I will do a webinar with students. It's a great idea.
My husband is a pathologist and he says 40% of the specimens are not formalin.
Absolutely.
He says 40%. This is the negligence. And that's why the cases are increasing, against the doctors.
Sure, ma'am. Absolutely. So I have this thing, nurses in my OT are very, very scared. So they know the moment the specimen comes out of the body, it has to go into formalin. If it is going for frozen section, it goes for frozen section. If it has got to go for paraffin section, it has to go into formalin straight away, because you could be declaring an ERPR positive patient negative if you don't fix the specimen correctly, and the fixation happens the moment the tumor is out of the body and has to go into formalin. Otherwise, you lose that vital piece of information.
So all these steps are very important,
Yes.
which most of us don't bother about.
Yes, but I think, every small piece adds to the big piece. And if you're trying to improve your results, all these small things add and, make it worthwhile.
Yes, yes. And it is the patient who's benefited ultimately.
Absolutely.
Why not? Why not? So, ma'am,
Thank you very much. I think it's been a great thing.
Yes. Thank you.
We should have you at least every 3 to 4 months, so at least the awareness among the women community reaches, and especially we people are pillars as far as the women health education is concerned. Unless we people know about it, things are really not going to go.
Yes, it was wonderful.
And congratulations, ma'am, on being elected the president of the Delhi Gynae Forum. Is that so?
Who?
Am I right? You?
No, no, that was, I
Madam,
think.
I'm the boss for the city.
Of course, I know that.
8 forums run under me.
Yes.
No, I read some message today which said
Yes.
Delhi
No.
Gynae Forum. What was that?
So, one of the forums, we changed the office bearers. Yeah. So the one who got nominated recently, she is arranging a webinar as a sort of
Malvika
introduction.
Sabharwal has been elected as the second president in the DGF Central. So for inauguration, she invites B.K. Shivani, and I told her this should be year after year.
Excellent, ma'am. Ma'am, आपके तो जोश का ना हमारा बराबरी.
Your bosses are very small worker, but they are very silent worker. Okay?
Ma'am, you need somebody like that to keep a good thing running,
Yes.
Our
Thank you
forum
so
is
much.
doing very well.
Very well. Very
Touch
well.
wood.
Very
Touch
well.
wood.
Excellent.
Touch wood. Touch wood. Yeah.
Right.
Okay,
Thank
Dr.
you very
Geeta,
much, ma'am.
thank you so much. It was
Thank you, ma'am. Thank you
a
so much.
pleasure to have
Thank
you.
for
And
inviting me.
Yeah.
And,
So 3 monthly, I'm going to invite you again.
Sure, of course. And I hope
Wonderful,
it becomes more, less